Good evening, all. A very good evening to our professors, consultants, residents here present, members of YNNF, and indeed all other participants. I'm sorry I dropped out of the meeting due to network issues, but I'm back, and I wish to welcome us to this month's edition of the monthly YNNF webinar. We have a very interesting topic ahead of us. We're privileged to have one of our fathers in the house as a senior faculty for the day, and he has joined us. I noticed on returning to the meeting that he's here with us, and I'm really delighted that we have the honor of having him participate despite his tight schedule. I'll leave further introductions to the day's moderator, who is none other than Dr. Bruno Arekandia of the ERA Specialist Hospital. So at this moment, I say a very big welcome. Without wasting time, I will hand over proceedings to Dr. Arekandia. Take it away. Dr. Arekandia, over to you, please.
Thank you very much, Dr. Guga. Good evening, professors, consultants, residents, and every attendee present on this webinar today. I have the privilege of moderating this webinar, for which I would like to thank the ESCOs of the Young Nigerian Neurosurgeons Forum. Once again, I welcome us to this month's edition of our webinar series. We shall be continuing on our sub-series that has been dealing with surgeries for common central nervous system anomalies. We're taking the part 3 today as advertised, and the focus is on frontoethmoidal encephaloceles. We have residents from the neurosurgery division of the Lagos State Teaching Hospital, Dr. Toluwanimi Ademola Popola, as well as Dr. Abimbola Adeniran. They will be taking us each for 25 minutes. Dr. Ademola Popola will be starting with the introduction, embryology and anatomy, classification and the pathology, while Dr. Adeniran will be concluding with operative principles. And then we shall entertain questions, after which we introduce the guest faculty for today. As has been mentioned by Dr. Guga, we are quite privileged to have a very senior trainer as a guest faculty for today's proceedings. We're looking forward to an engaging and robust proceedings. Of course, I'll introduce the guest faculty when the time comes. So without much ado, I would like to call on the first presenter to take the stage. Kindly mute your devices if you're not talking. And then if you do have questions, please post them in the chat box, or you can wait until it's time for asking questions and ask your questions on the spot. So Dr. Popola, over to you, please. Thank you very much.
Thank you, sir. Good evening, everyone. I'm Dr. Ademola Popola. I'm presenting Frontoethmoidal encephaloceles, the first part here for the neurosurgical division of LASIK. And this is our outline for the presentation. The word encephaloceles derived from Greek origins that translates literally to the hernia of the brain. It refers to abnormal protrusion of the brain with or without meninges and CSF through a defect in the cranium. These are rare occurrences, almost always congenital, but quite rarely can be acquired. The global incidence is put to 0.8 to 3 per 10,000 live births, with much less incidence in Europe and North Africa, with 1 in 35,000 live births. In Africa, the prevalence is estimated to be 2 per 10,000 births, with the Nigerian study reporting at 6 per 10,000 live births, with frontoethmoidal encephaloceles still being 20% of all encephaloceles in Nigeria. Occipital encephaloceles globally make up the predominant prevalence, with 75 to 80% prevalence. There's an interesting geographical distribution, with these encephaloceles being more common in Southeast Asia, in Burma, Cambodia, Thailand, Malaysia, Indonesia, and India, with they having a much higher incidence rate, with reported 1 in 6,000 live births, with a particular reference to Thailand, where the majority of these cases are reported from. There is a almost 10-to-1 ratio between anterior and posterior encephaloceles. Identify risk factors. These are from a landmark study among a Thai population over 7 years that noted the ethnicity of the Thai ethnicity as even within their populations as a high risk factor, while there are considerations for genetical risk factors as we see going forward. But one thing that stands out is the fact that this condition is particularly seen in people with low socioeconomic status. Other risk factors that have been reported are less considered in terms of their strength in contributing to diseases: advanced maternal age, long pregnancy interval, and a poor uptake of preconception folic acid supplementation that points to a neurotube defect. It is important to understand the embryology of this condition, because that helps to understand the pathogenesis and also the operative principles that are required. The cranium is developed from is divided into two major prenatal parts: the neurocranium and the visceral cranium. The neurocranium that is made up of the desmal cranium and the chondrocranium, which predominantly makes up the base of the skull. But the visceral cranium makes responsible for the development of, or it becomes the facial bones, facial skeleton. The bones that arise from the neurocranium, the parietal bones, frontal, sphenoid, ethmoid, and the temporal bones are referred to, while the visceral cranium are the bones listed in the image. The embryology of this will be incomplete without discussing the migration of the neural crest cells and also the paraxial mesodermal tissue, which both develop or create the mesenchymal tissues from which the structure of the cranium is formed. The cranial neural crest cells following gastrulation and neurulation, they start as in the fourth week of gestation, post-conception, start to migrate cranially. Migrate caudally and migrate cranially. These are all within the influences of multiple genes, the SH, that is the sonic edge genes, and many others, that eventually results in migration of mesenchymal tissue to respective locations, as you'll see going forward. But with the neural crest cells contributing to the craniofacial skeleton, the ganglia, the teeth, and endocrinally the thyroid cells. Now, this person. Can you hear me, please?
Yes, we can hear you loud and clear.
All right. Apologize for the break. All right. This image shows an axial image of the base of the skull in a developing fetus, that shows the areas that are developed from intramembranous bone formation that mostly arise from the neural crest cells, and these other areas from endochondral ossification. Particularly important in the case of the encephaloceles, frontoethmoidal encephaloceles is anterior, the junction between the membranous portion here and the endochondral portion here, where this becomes eventually seen in this image. This precortal cartilage eventually develops into the ethmoidal bone, and the frontal bone seems to approximate here. Important to see, anterior between them here is the foramen cecum that is prenatally transmits emissary veins and also has protrusions of dural extensions, which are expected to regress. But in a situation where this does not regress, there's a development of the frontoethmoidal encephaloceles. Now, these apertures in this image are important to note, because prenatally they are seen in all fetuses. Yeah, this is the foramen cecum here between the crest of the frontal bone and the ethmoidal bone inferior posteriorly. And here's the fronticulus frontalis that is a thin membrane, fibrous membrane that connects the nasal bone to the frontal bone. Now, these regress and eventually result normally in an approximation of these bones to one another. But in a situation where either of these apertures do not close, then there is space for herniation. And in this case, this is an example of the nasofrontal encephalocele, where there's protrusion or herniation of intracranial content through the foramen cecum and through the fronticulus frontalis. This fronticulus frontalis is normally covered by skin that separates the dura from the amniotic fluid. So approximately with the nasal bones and the frontal bones, then there's a resolution of what is seen as the encephalocele. And in the image noted D is where we have the frontonasal type, where there's herniation between the nasal bone anteriorly and the nasal cartilage inferior posteriorly. In an adult human, we expect that the bone should have fused, but in a situation where this does not happen at the foramen cecum here, then there is herniation of intracranial content. This is an axial image that shows the same thing with crystal gallery, the anterior portion of the ethmoid bone, approximating here with the crest of the frontal bone. And just between them is where we have the foramen cecum that is expected to obliterate in most adults, with only 1.5% of adults having a patent foramen cecum. And in a situation where by the age of 4, we expect this to ossify. Where it is not ossified by the age of 4, then persistently patent and calls for further investigation. And this annotated diagram shows the herniation of intracranial content through a persistent foramen cecum, which sometimes may be bifid. Now, the classification of frontoethmoidal encephalocele, or encephaloceles generally. Suwanella in 1972, in a landmark paper, described encephaloceles in 4 classes: occipital, sincipital, convexity, and basal, of which the frontoethmoidal encephaloceles are classified under sincipital, together with interfrontal and other craniofacial clefts. And they classified the encephaloceles, that is frontoethmoidal, into 3: the nasofrontal, nasoethmoidal, nasoorbital. Mahat in a couple of years later, added a 4th type, in which there was a combined nasoethmoidal and nasoorbital. This gives a basic understanding based on the appearances of the herniations, and as seen in these drawn diagrams. The nasofrontal frontoencephalocele, where the frontal bone is displaced above, and then the nasal bone and ethmoidal bones are displaced below. The nasoethmoidal, on the other hand, the frontal and nasal bones are displaced above, with the nasal bone being deformed. It's often broadened and has margins that are crimped, and so it produces an appearance of an hanging ledge in this situation. While in the nasoorbital type, there's a protrusion through the inferomedial wall of the orbit, passing between the frontal process of the maxillary bones and the lacrima and the lamina papyracea of the ethmoid bones, which lie posterior to the protrusion. So another classification, more recently, of bones viscous in 1998, classified this frontoethmoidal encephaloceles into 1A, 1B, 2B, and 2A and 2B. And this went beyond the basic classification of those, because they are oftentimes combinations of the different types of encephaloceles. 1A refers to the already described as classification as described as Suwanella and Suwanella in 1972. But 1B talks about the frontonasal type having orbital extensions. And other components of the 1B include the frontonasal defect with bilateral extensions to the orbit, frontonasal defect with cephalad extension of the herniation, and so on. While 2A refers to the nasoorbital type with having masses on both sides, which could be one side nasoorbital type, while the other side is nasoethmoidal type. So this just goes ahead to describe the different combinations of the frontoethmoidal encephalocele. And lastly, in 2003, more recently, Roj Vachiranola, who is a plastic surgeon, described this classification, a proposed classification that helps with preoperative determination of the extent of bony defects and how much of repair is required or how much is required to plan for the patient's repair and describe them based on the facial deformity present, the external bone defect, the size of the exit pathway in terms of both width and length, and also the presence of other malformations which we identify to have worse prognosis for the patient. This helps to counsel patients pre-operatively and also to determine the prognosis of the patient and also to plan surgically. So the pathogenesis of frontoethmoidal encephalosis have not had an agreed or a consensus because the etiology is determined to likely be multifactorial. That is, there's a nature versus nurture hypothesis, with the predominant schools of thought being the possibility of it being a neural tube defect, or more recently popular is the separation theory that describes a lack of separation between the neuroectoderm and the surface ectoderm as expected, such that there's persistent communication between the neuroectoderm and the surface ectoderm that results in the herniation. The neural tube defect also is a popular theory. However, the challenge with that is that most of these encephaloses are covered by normal skin, unlike what is expected in the traditional pictures of neural tube defects in other parts of the axial skeleton. So all these others are just attempts at describing what happens. In terms of the nature versus the nurture, that is the multifactorial nature. Multiple studies, particularly in Asian populations, have correlated the incidence with low socioeconomic class as described earlier. And because of the higher prevalence in Southeastern Asia, it's considered that there are possible racial and genetic predilections. However, up until now, no specific genetic sequence have been found. In fact, in that landmark study I referred to earlier, done between 1999 and 2006, a 7-year-long study of 160 patients, they did a genetic analysis of all these patients and found no obvious chromosomal biases. So they believe that it's most likely subchromosomal abnormality that has not been defined yet. So, and like I mentioned, when compared between people who dwell in these areas, there's certainly a significant difference for higher incidence in people who have low socioeconomic class and also dwelling in areas that are poorly developed. The natural history of frontoethmoidal encephalosis are not fully defined yet. Several authors have noted that the frontoethmoidal encephalosis grow larger with time, with Arifin et al. Reporting that the herniated sac was generally smaller at birth or grew with time. And in the Arifin et al. Series, they found that only 5% of their cases grew faster than expected for the age of the child. 90% of these cases in their cohorts were grown according to age and were noted to have ceased in size, that is, in increasing in size after the 8th birthday. The factors, according to their study, that affected the growing mass were the size of the bone defect. That is, a larger bone defect will allow more brain or CSF to pass through, particularly because the intracranial pressure will increase with age. The content of the sac that contains more fluid than solid are more likely to enlarge faster. I think that also stands to reason. A patient who has a short exit path, especially with the blowout, the large defect type, will more likely have a progressive mass than otherwise. These patients typically will present at birth with appearance depending on the location and the size of the mass. Typically will present as a mass that causes unilateral nasal obstruction, and these encephalosis typically will be seen in the nasal cavity and lie between the septum and the nasal turbinate, the middle nasal turbinate, described as a glistening pink or large encephalosis may cause obvious facial deformities and they will be sessile or pedunculated. The appearance oftentimes variable, most times variable, with the overlying skin being normal most of the time, or may have dyspigmented, soft or firm consistencies that oftentimes have excessive growth over them, which lends credence to what is seen also in the neural tube defect. A unique feature is the tendency to enlarge the compression of the jugular veins, which is described as a positive Furstenberg sign. And the other clinical features will be described by the second presenter. Associated abnormalities are seen both intracranial and craniofacial skeletal abnormalities. Intracranial listed above encephalomalacias, gray matter heterotopia, and callosal agenesis. Well, interorbital hypertelorism has particularly been described in this frontoethmoidal encephalosis with a classic description of the elongation of the face and suspected nasal deformities. Differential diagnosis, nasal glioma, neurinomas, hemangiomas, and as listed. The next presenter will be taking. Thank you.
Thank you very much. Thank you very much, Dr. Toranimi Ademola Popola. You agree with me that that was a well-researched and well-structured presentation. And you also kept the time. For those who joined us while the presentation was ongoing, that was Dr. Ademola Popola from the Neurosurgery Division of the Lagos State University Teaching Hospital. And next up is the second presenter, Dr. Adeniran Abimbola. Kindly take the floor. Thank you.
Good evening, everyone. My name is Dr. Abimbola Adeniran. I'll be taking the remaining part of the presentation. So just to refresh our memory, frontoethmoidal encephaloceles, as said by the earlier presenter, are congenital herniations of neurologic tissue through a bony defect in the upper central face. Surgical correction remains the choice of treatment. In managing these patients, like every other disease pathology, we start with an adequate history taking, an exam disciplinary for this patient. The history, the diagnosis is usually clinical, but the patients that present usually come on account of cosmetic defects. They come with complaints of reducible swelling in the upper face, which has been noticed from birth. Most of the time, this swelling has been increasing in size, and in most patients, the overlying skin over the swelling is usually abnormal. Other history that should be taken is history to rule out, or history suggestive of neurologic deficit, and to rule out other congenital anomalies. Then we also need to take a history to know the treatment that has been given to the patient so far. While examining, we do a general physical examination, a central nervous system examination. The central nervous system examination usually doesn't exhibit any florid neurologic deficits. It has to be done for the sake of completion of management. The major examination findings usually in the head, ear, eyes, nose, and throat, where there is a mass or a swelling, usually in the upper face between the eye. So to take note of the size of this mass, this state of the overlying skin of the mass, if this mass is reducible, and then the size, the shape, can also we can also estimate the size of the bony defect through this mass while examining. And then depending on what has herniated through this defect, there could be bruise or True's head. Also check for the occipitofrontal circumference, which can be suggestive of what is going on intracranially. For a full and tense, for a macrocephaly, if the OFC is above the normal limit, it can suggest that there's also underlying hydrocephalus that is going on. Or if there's microcephaly, it can suggest that there's associated craniosynostosis with this pathology. The frontanel, the state of the frontanel, the full tense frontanel is suggestive also that there's raised ICP, most likely from hydrocephalus. And then hypertelorism, which is common in patients with frontoethmoidal encephalocele, with longer intercanthal distance and interorbital distance. So the investigation of choice is the brain MRI contrast. It helps us to delineate the soft tissue anatomy. It shows the neural tissue that has been extruding from these defects, what is the content of the mass, and then the content or the other pathologies going on in can be shown by the MRI with contrast. Also, a brain CT scan with bone window helps to delineate the bony anatomy. And as indicated, an angiogram can be done and other investigations that will help for surgical procedure correction. This is the cranial CT scan. The sagittal cut shows the herniation through the foramen cecum of neurological tissue. And this is a 3D reconstruction of the bone window that shows the bony defects that this mass is herniating from. This is also an MRI that reinforces and explains what I've said earlier. So what are the indications for surgery? The major indication for surgery is cosmetic, but other indications include if there is recalcitrant seizure that contributed to this pathology, if there are other neurologic deficits, if there's recurrent nasal obstruction, or there's breathing difficulty, and if there's risk of infection or trauma of this mass, and that is an indication for surgery. Contraindications to surgery can be absolute or relative. The patient refusal or parental refusal to sign consent is an absolute contraindication. Also, if there's an uncontrolled systemic or CNS infection, then surgery cannot be carried out. Other relative contraindication includes poor nutritional status or failure to thrive in these patients. If there's severe hydrocephalus, the hydrocephalus has to be controlled first, either with a VP shunt or other means, before definitive surgery for the frontoethmoidal encephalocele is done. So the care of the patient is multidisciplinary, involving the neurosurgeon, the craniofacial surgeon, the ophthalmologist, the intensivist, and the anesthesiologist, but is not limited to these people listed above. It's usually preferred to do the surgery as an elective procedure between the age of 6 and 12 months, because by this time, there's adequate brain and skull growth. The child is safer to go under anesthesia, and it's believed that the nutrition is optimized and there's better general health of the patient. So what are the principles of repair? The first principle of repair is excision of dysplastic neurologic tissue. But it has also been noticed or said that as compared to occipital encephalocele, the herniated neurologic tissue in frontoethmoidal encephalocele is usually still viable. So it is essential to do neurophysiologic monitoring or testing for the viability of this herniated neurological tissue before they get dysplastic, so that we don't excise a viable brain tissue. Other principles include complete obliteration of the hernia sac, a watertight dual repair, a good bony reconstruction, and good cosmetic outcome. Intraoperative principles include the use of general anesthesia with endotracheal tube intubation. The patient is positioned supine and the head is placed on a horseshoe head holder. It can also be placed on an head ring or a Mayfield clamp. And then the upper limbs are adducted and the neck is extended, raised above the level of the heart to allow for proper venous drainage. Intraoperatively, it's advocated to have an hypotensive anesthesia, tissue dissection, and then the tissue handling should be minimal. Should also ensure that there's complete sac excision and there should be minimal blood loss. The surgical procedure can either be done endoscopically, it can be done through open approach, or it can be done as a combined approach. So the indications for endoscopic approach include the small to moderate sized encephalocele. If this encephalocele is in the anterior skull base or is intranasal, that's an indication for endoscopic approach. If there is no significant external soft tissue involvement, and it can also be used as a diagnostic tool just to delineate the skull base defect in these patients. Endoscopic approach is minimally invasive. Endoscopic approach is faster, so there's lower morbidity, there's a higher success rate, and the cosmetic outcome, since most of the patients present because of cosmesis, the cosmetic outcome is usually better because there's no scar tissue. But it's technically more difficult, especially when it's a large or complex effect. And then it might not be able to be used for encephalocele that has a significant extracranial component. So like the open approach, endoscopy is done under general anesthesia where the patient is positioned supine. Nasal decongestion must be done using adrenaline soaked gauze and a multi-layer reinforced repair of the skull base defect done. So there are some technicalities involved in the endoscopic repair. Because of the size of the nostrils, it is more difficult to do it microscopically. So it's usually done endoscopically, the endoscopic transnasal repair. And also because the flap used is the well-vascularized nasoceptal flap. That flap usually used to repair the skull base defect. And in children, this flap is usually not adequate. So the use of fat grafts, muscle packing, and facial reinforcement is advocated in this pediatric population. So for the open repair is done, the incisions or the access include a bicorona incision and a lazy S incision over the swelling. there are different techniques that has been described in the technique, the Hula technique, and more recently the Messi approach. I'll be describing the Chula technique in this presentation. So the first stage of the Chula technique is the nasal approach or the nasal incision, which is the lazy S incision. The use of this lazy S incision is done because it follows a natural contour, it relaxes the tension line, and it helps to remove as much damaged tissue as possible. So the vertical portion of this S starts from the midline point of the glabella. It crosses, it goes to the nasolabia. It goes to the lower nasal dorsum on the right and crosses to the other side to the nasolabial groove. That's the lazy S. But if the mass is pedunculated or it's a large mass, a reverse Y incision can also be done, which helps to improve the access in this patient. So after the incision, through blunt and sharp dissection, the tissues, or the mass is separated from the overlying covering skin, and then the periorbital tissue is also separated from the bony rim of defect. But after we do this, we can see the medial canthal ligament, which is usually dystopic. However, if this medial canthal ligament is not shown at this point, through a stab incision, we can also identify the medial canthal ligament, which will be useful in the procedure for the medial canthopexy. While doing this separation, it is important to pay attention and not destroy the lacrimal apparatus that is in the orbital tissue. So for the cranial approach, a standard bicoronal flap is done and raised down to the supraorbital rim. This, while raising this bicoronal flap, it's important to leave the subperiosteum, which might be important or might be useful while doing a dural repair. So after we do this bicoronal flap and raise it down to the supraorbital rim, a bone graft or a bone flap, an osteotome, is made in a T shape. So the transverse portion of this T-shaped flap starts from 2 cm above the frontozygomatic suture. It goes upward, the T-shape, and the longitudinal portion comes down towards the nasal bone. So that into 1, 2, 3, which will be useful for patients with hyperthyroidism. If the patient has hyperthyroidism, on the Mayer's tray, the bone graft can be divided. The middle portion of this bone graft can be taken out, and then so the middle portion is taken out. The 2 remaining parts of this bone graft is wired together with a wire mesh to form a T-shaped osteotome. This remaining bone graft will be useful while doing the nasal reconstruction. So this next step is to close the internal bony defect, but this step is usually not done all the time. It's largely dependent on the size of the defect, and the closing of this bony defect is after resection of the mass and a watertight dural repair has been done. A titanium mesh is placed in an inlay manner over the defect, but the titanium mesh is not always indicated, especially if it's not a large and bony defect. So as I said earlier, the free portion of the T-shaped osteotome is moved downward. That's the yellow. So this is the 2 portion that has been wired together, and the middle one, number 3, is moved downwards towards the lower end of the T-shaped bone flap, and then it is used for nasal reconstruction. Other things that can be used for the reconstruction is the costochondral graft, a costochondral graft, if available. So the next step is to do a medial canthopexy. It's usually done in the presence of the ophthalmologist, actually usually done by the ophthalmologist, where the ligaments are detached. You detach the ligament from every abnormal attachment, and then through subperiosteal dissection is also removed from the orbital rim. And the medial canthal ligament is now attached to the medial portion. The canthal ligament here, to the lateral portion of the bone flap is attached here and is also attached here using a 4-0 prolene or a 4-0 vicryl suture. Attention is paid also to release the periorbital from the orbit and the anterior cheek while doing this canthopexy, because if that's not done, then the repair will be under tension. So after this is done, then the nasal soft tissue reconstruction is done. The excessive, as we said earlier, the skin covering this mass is usually abnormal. It shows signs of degeneration. Either there's hyperkeratosis, there's hyperpigmentation, or there's scarring. So the tissue is excised as much as possible to allow for adequate cosmetically appealing skin closure without compromising the skin closure. So the other technique is also a technique described by Hula. It's technically the same as the Chula technique. The difference is that it is a full bone flap that is done and not a split graft. And then the dura is traced on plate, the base of the skull, and detached from the base of the skull. That's the major difference between the Chula and the Hula technique. There's also the Messi ship approach that has been described and has been used in African countries like Senegal. Here, they do an H-shape incision on the mass instead of an S-shape incision. And then the bone flap is more extensive. It starts from behind the hairline. It's taken and block as a flap and constructed on the Mayer's tree. That's the major difference. They notice that the H-shape incision helps, it gives better access to the mass, and it helps better with dissection and gives a more cosmetically appealing final closure. So as I said earlier, there are points to note. It's not every time we do the skin incision, and we should avoid it if possible, because that will lead to a better outcome. If there are other pathologies, like hydrocephalus, for example, the hydrocephalus has to be treated before the repair is done. Other pathologies that is associated with this disease, like the arachnoid cysts, it also has to be taken care of, because if that is not done, the raised intracranial pressure is persistent, and it can help to, break down the dura repair or failure of the repair. And before excising any herniated brain tissue, neurophysiological testing is important to check for the viability of this brain tissue. So we check for recurrence, if there's any new neurologic sign and symptoms, and we check for the aesthetic outcome during the follow-up visit of this patient. We can also check how the patient has fitted into their social life and if there's any functional problem. Complications include inflammation of the lacrimal glands, CSF leak. There could be post-op meningitis, and in extreme of conditions, in extreme situation, death can also happen. This is just a table checking for the CSF leak rate following different approaches. And the Chula technique that was described had the lowest CSF leak rate, which is about 2.8% compared to other repair techniques. So in conclusion, frontoethmoidal encephalocele is a congenital craniofacial deformity, and it remains a challenge to the neurosurgeon. The commonest cause of presentation, or the most common cause of presentation in this environment, is cosmesis. The treatment is multidisciplinary, and the prognosis is usually excellent if the repair is done early. Thank you very much.
Thank you very much, Dr. Abimbola Adeniran. You also agree with me that that was quite an engaging and insightful presentation. We'll soon be calling on our special guests, but before that, some questions have been raised, and we're going to call upon our presenters to attend to them. We're also welcome to raise your virtual hands and ask any question, as well as pass any comments. Dr. Ibenwoko asked the question, and he said, what are the genetic risk factors? That will be for our first presenter, Dr. Toroanimi.
Thank you for the question. Question about genetic risk factors. Like I mentioned earlier, is that no specific genes have been identified. However, on account of the pattern most of the cases are sporadic, but for instance, it's one of the type studies I made reference to, they found an increased incidence among siblings, particularly monozygotic twins, which points to a possible genetic relationship. Also, the particular presence in particular ethnicities, although those ethnicities also have a higher risk of interfamily marriages. So all of this contributes to the fact that there's possibly a Mendelian pattern of inheritance that shows that is responsible for this presentation. But up until now, from my studies and from the research I tried to do, I didn't find any particular genetic references, only that I saw one study that said that in all the chromosomal analysis among 160 patients, there was no aneuploidy or any abnormalities in the chromosome. So they suspect a subchromosomal defect. Also, the separation theory refers to a possible deficiency of genes responsible for apoptosis. So in a case where those genes are studied, it's quite possible that there will be deficiencies or defects with genes responsible for apoptosis. So all of these are just theories. Nothing specific or concrete has been reported as of now. Thank you.
Thank you, Dr. Tolanimi. Fair enough. I think you've done justice to the question. Dr. Nwoko, if you are still on the line, I think you may want to throw more light on your second question. What are the pathology of this condition, and the reason for surgery, or if this reason for surgery is basically cosmesis? But while we're waiting for that, let's take Dr. Moses Adakun's question. He is asking, wouldn't earlier or concurrent cerebrospinal fluid diversion better facilitate the ease to do open repair? That will be for our second presenter, Dr. Adeniran. Dr. Adeniran.
Diversion for the hydrocephalus. Yes. So I said earlier CSF diversion will be preferred because it will, help to normalize the intracranial pressure, because we know the raised intracranial pressure also puts tension on the dural repair and is a risk factor for failure of this repair. So it can be done concurrently, but if it's done earlier and then on its second stage, the repair is done.
All right.
Lastly, intracranial pressure matters.
Okay. All right. Thank you for that, Dr. Adeniran. The final question in the chat box is from Dr. Tengu. He said, many thanks for the presentation. Is there relevance for Vactel relationship evaluation in examination of these patients? Are there syndromic relation for this pathology? Again, question goes to the second presenter.
There are syndromic associations, but most of these associations doesn't really follow the Vactel. The syndromic association that has been mentioned are the Frazier syndrome, the Robert syndrome. They could also be associated with amniotic band syndrome. And most of these syndromes, they don't have the Vactel association. So, but for completion's sake, during examination, the Vactel should also be at the back of our mind and we should examine. But in the course of the literature search, there was no strong relationship with the Vactel association with this disease pathology.
Well said. Well said. Yeah. There's someone just dropped another question in the chat box. Just a minute. Dr. Obiabuken is asking, at what point do you check for the neurofunctionality of the herniated tissue using the endoscopic approach? And what do you do with the tissue if it is not functional? Dr. Adeniran.
Okay, so part of the principle of repair is complete excision of this plastic tissue. So after the mass has been separated from the surrounding structure and it's time to either reduce or excite this tissue, the neurophysiologic monitoring is done. And if the brain is found not to be viable, then it is excised because it's this plastic brain tissue. You don't need to take care and return it back into the cranial cavity.
Thank you very much. Well said. We've come a long way, but there's still room for comments or additional questions from our listeners. Please, if you wish to do so, just raise your virtual hand and I will recognize you. And in the absence of further questions, I would like to introduce our special guests for his surgical pairs and words of wisdom regarding the presentation. He's no other than Professor Adefolari Obanishola Malomo, who is a distinguished professor of surgery and honorary consultant neurosurgeon at the University of Ibadan and the University College Hospital Ibadan. Well, he's recently retired, but definitely not tired. He began his academic career as a lecturer way back in 1991 and was promoted to a professor back in 2007. He has over 4 decades of experience in clinical practice, in teaching, research, and specialization in neurosurgery and neuroanatomy. He's a graduate of the University of Ibadan, and he holds a master's degree in bioethics from the University of Toronto. His professional development includes training in top Nigerian institutions and fellowship from the West African College of Surgeons and the International College of Surgeons. He has served in various capacities, including the acting head of anatomy, CMAC at the UCH, the Dean of Faculty of Clinical Science at the University of Ibadan, and Director at the Institute of Neurosciences at UCH. He's currently the head of department at the Department of Anatomy, Federal University of Health Sciences in Ogun State. He's an accomplished teacher and an examiner at both undergraduate and postgraduate levels, and has served as an external examiner and assessor in numerous Nigerian and international universities across various disciplines, not just limited to neurosurgery. He's a highly respected figure in the fields of neurosurgery, anatomy, bioethics, and has made outstanding contributions in the development of institutional ethic framework in Nigeria. He has trained and mentored senior colleagues as well as other colleagues in neurosurgery and remains a source of inspiration to younger and upcoming surgeons. His national leadership roles include chairing committees at the Nigerian Medical Association and West African College of Surgeons. And he has also played a pivotal role in drafting the Nigerian Code of Ethics for Human Research as the National Bioethics Framework. In recognition of his service, Professor Malomo has been elected a Fellow of the Nigerian Academy of Medicine, and he is a serving member of the National Bioethics Committee. His career, you agree with me, exemplifies a seamless integration of clinical experience, academic leadership, and ethical advocacy in healthcare. He has authored and contributed significantly to the body of knowledge in neurosurgery, anatomy, and bioethics through several textbook chapters, and over 110 scholarly articles published in reputable peer-reviewed journals. His academic work reflects a sustained commitment to advancing medical science and education in Nigeria and beyond. Please, without much ado, I would like to welcome Professor Malomo. Professor,
yeah,
over to you, sir.
Thanks, sirs. I see. Can you hear me?
Yes, I can hear you loud and clear, sir.
Yes, sir.
Oh, thanks a lot. You know, it's a privilege, as I told the convener, and I've had a great time listening to the rigorous and succinct presentations. And our moderator, thanks a lot for a great job that you've done. The presentation for me reflects the continuing advancement in neurosurgery in Nigeria by young and old people. But this being from the Young Neurosurgeons Association, I think it's just fantastic. I have a few suggestions about all these presentations. I think when we're using someone else's chart or illustration or whatever, it's good to just note it very briefly on that slide, if possible. I know the references cover a lot of primary sources, which is a credit, really. They use a lot of primary sources in their references. And also, I hope that we have a library in which we, electronic library, in which we store all these presentations and where members can access it. Even if you're just drinking Coke and you want to flip over things, it's amazing. Well, a few comments really. I think this presentation should spur us to take a look at this condition nationally. We could just say sincipita and encephaloceles without restricting it to just frontoethmoidal varieties, or even encephaloceles generally in Nigeria. Presentation, investigations done, what we find and all that, and complications of surgery and so on. This is something that will be information at national level. I like the presentation. It's not like a big corrections, but just a few points. You know, recurrence is a problem if you don't take care of the inner outlet, just the foramen cecum in its area. And the presenters have told a good deal about the soft tissue and the hard tissue that you can use, and there's a need to pay attention. All those other multidisciplinary people are very vital. It's better to start with them than to get them after you start having problems. Now, the canthal advancements, Professor Shukumi has done quite a few of that in other congenital malformations. So there are things that can be done in Nigeria, but they are facilitated if you have power instruments. Now, somebody was talking about chromosomal issues, and they're just associated. The presenter is right. There is not currently a direct link, but there are suggestions of chromosomal issues related to this. The complex, the vector that is referred to, yes, there are other syndromes that are linked with frontoethmoidal encephalocele, which also suggest. And then there are clusters in Southeastern Eastern Asia that has been mentioned too, which also suggest familial clusters, which suggest there might be something chromosomal. Incidentally, the effort to see if the genes responsible for metabolizing folic acid are usually, no, that's not conclusive, although there are suggestive findings. Trisomy 13 and 18, I think, might be some syndromes that are also associated, which those interested in syndromic, rightfully interested in syndromic features would like to look at. There have been a few anomalies of chromosome 4 that have been documented in different segments, but as is known, these are not conclusive and they don't always lead to just this condition. They are associations. So the question is very valid, but it's at association level. And one good thing about that is that any of you can take it up and take a better look at these issues from different angles other than what's been stated. But above all, I think these presentations, apart from information and education, should also keep generating, because the presentation today has left so many gaps, unknowns, which people can team up, gather up, and look at how they can study this. One easy one is just a descriptive study nationally, maybe last 5 years or whatever, whenever those involved has done this, and a few other people. So these are, Uche has done a few, Ukachukwu has done a few. These are things we could look at. Every time we identify a gap, it's good to go ahead. One last point I'd like to leave behind is that, you know, in our environment and for the world, we should also remember to add a footnote about medical humanities aspect of these issues. You know, looking after a baby involves looking after the family, not just their finances, but their mental health as a group. The more we pay attention to this, the better it is for them, and the better the ultimate care of pediatric children will be. But whether it's pediatric or not, looking after the mental health of the index person and those affected by what we're treating is something that will go a long way. Above all things, I must say, it's been a great delight. You must know that I've learned myself, and it's amazing. And that's the proof of the life of neurosurgical practice in Nigeria. Everybody has known that, I must say, world over. But we must keep pushing and pushing ahead. Finally, advocacy. Let's remember that no matter how much we know and can do, unless national policies support us, we will not be able to do as much as we should have. And you shouldn't just complain. You should map out how you get closer to decision-making process so that you are part of the process. You're anticipatory, you're proactive, and not have to protest or complain or describe deficits in national policies and so on. As I've said, it's a very wonderful occasion. I've said we should pay attention to, somebody asked about hydrocephalus. Yes, but usually people can do without necessarily. However, in severe hydrocephalus, that is also high pressure, as the presenter answered, it is mandatory, but it's not a routine that people have to undertake, just like he said. So our moderator, Sabrina, thanks a lot. It's been wonderful. It's like you trained as an MC before. Thank you. And Young, our convener, thanks a lot. The entire group is just amazing. As I've said, let's have a library that members can access as they want. Let's form research groups that can address gaps that are identified. When we use people's materials, let's acknowledge them, no matter how faint the thing might be. Some of the slides carry it naturally, but others, we should add it. And above all, let's look at the psychosocial health of not just the index patient, but the family as a whole, and address this. Let's get involved proactively with policy by sending appropriate report, by being close to those who make it, and let's advocate for the various categories of patients that might need us as a group of specialists. Once again, it's a delight, and I'm very grateful for this opportunity I've learned, and thank you very much indeed. Thanks, God bless.
Thank you very much, sir. We're indeed grateful for sharing your insights, sir. We hope that the next set of presenters for the next month will take into consideration recognizing sources of their visual aids and figures. We also hope that the YNNF ESCO will look into the issue of an e-library, and then everyone can also look into the opportunities for fertile research grounds, as pointed out by the special guest. We've come a long way, and you all agree with me that we've been treated to a well-structured presentation that we will find beneficial in our clinical practice going forward. At this point, I will like to call on Dr. Guga. I'd like to hand over the microphone to him to take us down the concluding part of the presentation. Thank you.
Thank you very much, Dr. Arakandia, for a beautiful job. You have been commended by Prof, so I have nothing to add to that. And I appreciate Prof really for making it to this evening's meeting. We aimed at achieving that last month, but Prof was quite busy out of the country at the time. But I'm glad that he made it a date with us. He promised that once opportunity I was going to be here, and it indeed has made it happen. I appreciate you greatly, Prof. Thank you so much for the insights shared. We've taken the words of advice. I think looking at the number of young neurosurgeons in the country and those coming up, there's really so much we could look at in terms of filling the gaps. We appreciate your encouragement in that regard. And regarding the e-library, I think the webinar committee actually uploads these presentations on the YNNF subsection of the NANS website. So the presentations are actually there for reference and for utilization by our members. We appreciate the advice. Thank you so much. Special thanks to our presenters, special thanks to attendees from other sister African countries. I've seen a few names, Dr. Banson and a few others that I was able to identify. And special thanks to our other trainers who came on board and those who asked questions. We appreciate you. let's make it a date again next month as we look at another topic as far as this educational program goes. Do have a very blessed weekend ahead. Thank you for coming, everyone. Bye-bye.
Thank you. Bye now.